your country, but it's not standard here. So you are privileged to be opening this session on headache and pain management as the first time in the King Faisal 1 o'clock lecture.
No, they're not. They're eating lunch.
Okay. So we talked about things that would be of general benefit to people regardless of specialty, and figured that headache and pain management would be a useful thing because they often are very difficult patients to deal with. They cause a lot of distress and pain in clinicians, and so this is what we were going to do, a very brief overview. Stop me if I'm talking too quickly. We'll start with headaches. So there are some general categories that are useful to kind of conceptualize when you're thinking about headache. Migraine is probably the most commonly thought of for the neurological folks. Musculoskeletal is by far the most common kind of headache in general. And then I added cluster and temporal arteritis just because they're things that you don't want to miss because of potential complications. One of the most useful things I was ever taught was during my second year in medical school by a neurologist who said, the first thing you think about is when do you have to be worried with a headache? And the questions that you want to answer are there warning signs? Is it worse in the morning? Is it worse when they're lying down? Is there anything that would make you think that there might be a mass lesion causing increased intracranial pressure? The thunderclap headache, that sudden onset with the worst headache of your life kind of headache, we'll touch on tomorrow because we're going to do stroke, and that's more in that category. Any headache associated with focal neurological signs, diminished level of consciousness, anything like that. And then anybody who's had a substantial change in their headache, a new kind of headache. So if somebody's had headaches all their life, but then there's something that's really different and unusual, it's something that you have to kind of take notice of and make sure that there's nothing new going on. So one of the difficulties in headache is that there are so many pain-producing structures in the head, the face, and the neck, and you have to think of all of them because they have different referral patterns, and they can cause a lot of confusion about where the pain is actually coming from. And so the musculoskeletal structures, which there are many of, radiating from the neck, jaw, forehead, around the whole cranium. The dura, as everybody here knows, the brain is not a pain-producing structure, but the dura is. The vasculature, either vascular pain, nerve and nerve root pain, so high cervical nerve roots can certainly cause headache. You have occipital neuralgia, so you have occipital nerves that come out at the base of the skull and can cause a neuropathic type pain radiating up over the head to the eye. Then you have sinus problems, dental problems, eye problems, all of those things. You just run them through your head, and is there anything that's pointing in a particular direction to help you narrow down the source of the pain? So migraine, the current thinking by at least one of the big headache gurus in the United States is that all headache is migraine. Now, there aren't that many people who agree with that statement. I certainly don't. Migraine was classically thought of as being a unilateral head pain syndrome, but as many people know, it can be bilateral, it can be any kind of distribution. It's usually throbbing pain, pounding pain, but it doesn't have to be. There should be nausea. It doesn't have to necessarily progress to vomiting, but nausea is a pretty good indicator that there's a migrainous feature. Sensitivity to light and sound, very typical. And then you may or may not have an aura. There are a lot of people who have migraine and they never develop an aura, but the aura is usually a visual thing, flashing lights, jagged lights. You can have loss of vision. Those are the common ones. Heat wave with little wavy lines in your visual field. So the original thinking was that it was a vascular headache. It was primary vasculature. It started with vasoconstriction, and then there was a rebound vasodilatation that caused the throbbing, pounding pain because the dura was sensitized. That thinking has been shown not to be the case. It's not a primary vascular issue. It's a neurogenic issue. So something, we're not sure what, triggers neurological inflammation that then sets up sensitization of the blood vessels, the dura, and surrounding structures like the trigeminal neuralgia kind of picture you can get with migraine. All of those cause an inflammatory cascade. There are dozens and dozens of factors that they have identified as being important for sensitizing the neurons there. And I won't go into it because it's detail that you don't need to know. But the end result is that you have an inflammatory situation that can then cause neurological deficits. So you can actually watch in functional imaging, functional MRI or PET scan, you can actually watch what's called spreading cortical depression as the cortex actually kind of shuts off. And that's what's going to give you the neurological deficits you can see with a lot of migraine. Visual changes, you can have stroke-like symptoms, things like that. And so there's this cortical spreading depression that occurs if you allow the migraine to proceed. And so it's a complicated process that, left unchecked, can actually go on for days. And this is just a little graph, a little cartoon that shows a couple of the main inflammatory players, the neurokinins, certain growth factors, and the sensitization that occurs both to neural structures and vascular structures that combined give you the typical migraine picture. So there are a number of risk factors or associated factors that probably everybody already knows. Family history is big, especially migraine with aura. There's a strong genetic component. Hormonal fluctuations, so prior to puberty, the male-female rate is equal. Once you hit adolescence and hormonal changes begin, you end up with a significant female predominance. After menopause, the rate goes down and you have a more of an equal distribution. Hormonal fluctuations are key, but also estrogen itself is pro-migraine, and progesterone helps to relieve migraine. And so there are certain times of the cycle where women will be much more likely to have migraine, and that's a catamenial migraine, is when it's closely associated with the menstrual cycle. Sleep deprivation is a big one. Unfortunately, it's one that is it's a difficult problem for people who are busy, and for those of us who got her first migraine during internship, I can vouch for sleep deprivation being very significant. Alcohol is a big problem, especially red wine. Certain aged foods, chocolate, things like that can trigger migraine. And then you can have other sources of migraine. If you're a migraineur and you have a tension headache, it can become a migraine. That's called a secondary or a transformed migraine. So it can start as one headache, and then you can end up with a migraine, which can be confusing because you might treat the migraine and the person still has the headache because that initial cause of the headache hasn't been addressed yet. So treatment are two general categories. One is an abortive treatment, so you're going to treat after the fact, after it's already come on. That's for people who have infrequent migraines, people who are going to be less compliant taking a daily medication, people who have the catamenial migraine, where you know when it's going to happen. That's actually a really convenient thing. Anti-inflammatories, so the non-steroidal anti-inflammatories, ibuprofen, naproxen, indomethacin, are all very, very effective. The triptans have been a significant step forward in treating migraine. So that's sumatriptan. There are a whole host of them. They all work the same. Opiates, if you are really in trouble and you really have no other way to avoid severe pain. And then the ergots, which are really hardly ever used anymore in the United States because of their side effect burden. They tend to be difficult to tolerate. I'm not sure if they're still used here, but they've fallen out of favor before I even entered training. And then preventive treatment is the other option. That's for people who have frequent migraines, people who are so disabled they're missing work on a regular basis, they can't do what they need to do to live a functional life. You have beta blockers. Propranolol is the one that's most commonly used because it crosses the blood-brain barrier the most effectively. Calcium channel blockers, verapamil and diltiazem are often used. The anti-seizure medications, probably all of them have been used at some point. The two that are the